Thanks very much. I feel slightly nervous giving this talk for a number of reasons. And I suppose one reason is the psychiatrist's approach just sort of suggests there's a definitive psychiatrist's approach. Now, if you sent most patients with chronic fatigue syndrome, ME, to your local community mental health team, you will not get a very helpful or useful answer. Psychiatry, mainstream psychiatry, is not designed to deal with this group of people. It is only a certain small number of clinics where there's been a research interest, like Peter's and like Simon's, which have developed over time and developed the expertise to deal with these sorts of very complex presentations. So the psychiatrist's approach, you could have a very different set of answers. And I suppose the question which was asked at the end of one of the other talks about, should we be getting psychiatrists involved? The question is more about what sort of skills should a clinical service have available to it, rather than the actual guild issue of who does it. And it may very well be that the right sort of place is a different, a different specialty, as long as there are the skills to pick up the sorts of things I'm going to be talking about. Now, we had Simon's slide about kick psych out of CFS or ME. Why should we have the presence of psychiatry here? I should say the other reason I'm a bit nervous is actually that the psychiatry doesn't see a great deal of this. I mean, we haven't had a talk from a physician, a neurologist, for example, about what their approach in secondary care is. And I imagine most of the referral processes from primary care to secondary care are into mainstream secondary care clinics. And from my own experience, very wide variation in practice and how people get managed, which I think contributes to some of the controversy and problems. But why have a psych in CFS? Firstly, I want to talk a little bit about misdiagnosis. We've heard a lot about psychiatric comorbidity, but I'm going to talk a bit about misdiagnosis. I'm going to talk a little bit about suicide. I'm going to talk a bit more about comorbidity, and you're going to see some of the same slides you saw earlier on today, so I won't dwell on them too much. And then I'm going to talk about the impact of psychological processes, and then a bit more didactically about actual assessment and what one should be doing. So let's take misdiagnosis. I'm very grateful to Peter White because he dug up the figures for his last 209 referrals from his service. And these are 209 referrals. They've usually, I imagine, had quite extensive contact with a general practitioner. They've usually, I imagine, had quite extensive contact from several different medical clinics, neurology, infectious diseases, gastroenterology, whatever. They've seen lots of different people. And yet, in this service, only about half of them the firm diagnosis of CFS is made after an extensive process of assessment. And Peter's diagnosing about a quarter of them with alternative medical diagnoses, very often sleep disturbance, primary sleep disorders, but also other conditions, the occult cancers or whatever. And another quarter with alternative primary psychiatric diagnoses. And I think this is one area where having access to psychiatry matters. There used to be in the BMJ a column which was Lesson of the Week. And Lesson of the Week usually was about a metabolic physician who had diagnosed porphyria in a patient who had previously been banged up in an asylum for the last 15 years. And Bob's your uncle, porphyria is diagnosed, and everything's better. And aren't I clever? Well, very rarely does psychiatry have the alternative. And the alternative is someone who has been isolating himself, maybe complaining about visual disturbances, being sensitive to noise, sensitive to light, isolating himself, maybe at the start of a kind of university career, who has become increasingly kind of focused on internal sensations, and who has barn door, when you do a proper psychiatric assessment, barn door psychotic illness. And it is terrible to misdiagnose someone with an eminently treatable psychiatric condition like that. And that is what most people, most psychiatrists who work in this field have had experience of. So psychiatric diagnosis matters. Most of these 47 aren't people like that. Most of these 47 are people with primary psychiatric disorders like anxiety or depression, where you don't need to invoke chronic fatigue syndrome. I think that's right, Peter. You don't need to invoke chronic fatigue syndrome as a kind of separate entity. They've come with a label of chronic fatigue syndrome, or query chronic fatigue syndrome, or query ME. But actually, when you look at them, it's a classic history of agoraphobia or depression. And that implies also, of course, that the psychiatric diagnosing these conditions, isn't saying that, that it's all the same. It's actually saying that there is something which is distinct, which we recognise as chronic fatigue syndrome. Now, of course, there are reasons for misdiagnosis. Simon's talked already about symptomatic overlap. So, if you look at the diagnostic criteria of depression, they overlap with the diagnostic criteria of chronic fatigue syndrome. People with early psychotic illnesses isolate themselves and behave in ways where they get away from their peer group and feel unwell physically, and so there's diagnostic overlap. And physical symptoms, classically in disorders like panic, where people become overwhelmed by physical symptoms. So that symptomatic overlap matters. There's also demographic overlap. So these all tend to be disorders starting in the beginning of people's adult life. Most people with chronic fatigue syndrome we see in the clinics very often have had it for 5, 10, 15 years, but they usually are finding a history going back to the time when they're making the step into adult life. And that's exactly the same for most primary psychiatric disorders. And of course they get a label because of the problem of stigma. They get a misleading label because of the problem of stigma, that it's a more acceptable diagnosis often to be suggesting both from family, from medicine or whatever. Tragically, there's the problem of suicide. Now, this is the follow-up of a large series, over 1,000 patients, 1,200 patients seen in North America. This is Dirje Buchwald's clinical service, and it's looking at mortality over a period of a mean of 9 years, and it's using the kind of standard procedure to follow people up to identify people who have died. So you get very high follow-up rates, and all-cause mortality in chronic fatigue syndrome. This is both chronic fatigue and CFS going to this service. All-cause mortality is actually very similar across the board. So this is the reference sample. This is what you'd expect. And actually, men are bang on it, and women are slightly below it. So chronic fatigue syndrome not increasing all-cause mortality. Okay? But suicide, and look at these figures. These are frightening. Okay? These are your standardized mortality ratios for suicide if you're presenting in this clinic. Over the next 8-9 years, you are seeing people who are killing themselves about 8 times more than the general population. So the psych in CFS matters because people are at risk of suicide. We have to be able to have the skills to ask the difficult questions about suicidal ideas. Is your disease, have you felt so despairing that you've had thoughts you'd be better off dead? Have you actually made any plans to harm yourself? Have you ever harmed yourself in your life? These are important questions, and we shouldn't be frightened about asking them because it matters. And then, of course, comorbidity. Well, I said you'd seen a lot of these slides before, so I won't labour it too much, but I think there are a few sort of points I want to make. Firstly, the psychiatric disorders in these case series, psychiatric disorders which are diagnosed in people who've got through Peter's hoop. They've been diagnosed with the CFS in the clinic, but there's still a very high proportion of these patients meeting criteria using standard diagnostic interviews in order to get recognised ICD or DSM criteria psychiatric disorders. So most of these disorders are, of course, things like anxiety disorders or depression, and compared, of course, to physical to controls who have physical illness, the rates are higher. This is what Simon was making the point already. This is why you need psychiatrists in general hospitals, because there's an awful lot of psychiatric disorder amongst the people with these types of physical disorder, and this is why you need psychiatrists involved in chronic fatigue syndrome, because there's an awful lot in the chronic fatigue syndrome clinic. Now, you can think about this comorbidity in terms of predisposing comorbidity, precipitating comorbidity, or perpetuating comorbidity, the 3 Ps beloved by psychiatrists. This is just the data from the 1946 birth cohort. So we had people ask the question at age 53, have you ever had the diagnosis of chronic fatigue syndrome or ME? And most of those who said yes had only had it in the last 10 or 15 years. And then we looked back in the records to see the proportion of them who actually had psychiatric disorder in early life, between 15 and 32. And there was a composite score which was made up of a range of different things to do with attending your GP with a diagnosis which was labelled as psychiatric, or getting admitted to hospital. And quite a high proportion, a much higher proportion of the people who had chronic fatigue syndrome had this history. A much higher proportion of the people who had the history of severe difficulties in early life went on to develop chronic fatigue syndrome than the rest. But of course, not at all inevitable. These are percentages, so it's a very small proportion of people going on to make that label on themselves later on. And this, using a psychiatric interview, the present state examination, scores age 36, just looking at the odds ratios now of your chances of having chronic fatigue syndrome later on. So this is chronic fatigue syndrome nearly 20 years later, and a very strong association, if you've got more scores on this, that you're more likely to get the disorder. So a powerful prospective association going on in the background. Doesn't mean it's the same thing, but it means that you need to take account of it. The precipitating factors, well, the high-risk studies, ours and others, which have looked at serious viral infections, we've heard this already, find that there's a high rate of chronic fatigue or chronic fatigue syndrome in people with things like viral meningitis or other serious viral infections. You've heard all that this morning. Two factors amongst those people who'd had the serious viral infection which seemed to predict whether they went on to get chronic fatigue syndrome. One was a past psychiatric history. This was asked in retrospect, so it's not quite as neat as the other ones. You're asking them, have you ever visited your doctor for an emotional problem prior to your illness, prior to the viral infection? And again, depending on how you cut the cake and diagnose the fatigue, quite a high association. Prolonged convalescence, again, people who were who had the longest time with the acute viral infection to recover were most likely to go on and get chronic fatigue syndrome. Now that may mean, of course, that they had the most severe infection, or it may mean that they had the reaction to the infection which was unhelpful. But it implies that there are processes which go on, which matter. And then the perpetuating, and Tony, I think, I agree very much with what Tony said, that the perpetuating factors are where we kind of have the best grip of a lot of these risk factors. Psychiatric disorder in itself, this is people in primary care with substantial unexplained fatigue, and this is your chance if you've got substantial unexplained fatigue in primary care from a huge multinational study looking at GP attenders, and it's your chances of still having the fatigue 1 year later if you've presented with high scores on the GHQ. So the GHQ for the non-psychiatrists is a kind of psychiatric ESR. It kind of tells you roughly how ill or well you are. So the people who are at this end of the scale are actually very symptomatic in terms of psychiatric terms, and they've got a much higher rate of remaining fatigued 1 year later. This is perhaps people in the acute stages going on to becoming more chronic. So it matters there. And in a systematic review we did, looking at all the studies which had looked at prognostic risk factors for chronic fatigue syndrome, what you find is, firstly, that prognosis is poor. Okay? There's no getting around this. The median full recovery rate in these different studies, and I have to emphasize they're very different in terms of quality and how they diagnose CFS and so on, and the length of follow-up. But the median full recovery rate was only 5%. So very few people are actually getting substantially better without active treatment. About 40% of people improve a bit, so make some form of improvement. And the rest of the sample, the 55%, are either staying pretty well all the same and one or two getting worse. But it's basically a pretty gloomy prognosis. We looked at return to work, and only about between 8 and 30% in 3 studies which reported it actually said that anyone had returned to work in their samples. So the actual rates of return to work are very, very poor. We have to deal with the fact that this is, by and large, a condition which remains stable. But what about the risk factors? Well, the risk factors, again, tell us that in 18 studies which reported any risk factors, 4 of these studies said that older people were less likely to get better than younger people. The 2 negatives mean that it was evens. It didn't make a difference whether you're older or younger. So basically, older age seems to be a risk factor. Having a longer duration of fatigue, no surprises. Having multiple symptoms, no surprises. Psychiatric disorder, 7 out of 9 studies which reported it found that that was important. And physical attribution. How you actually understand your symptoms, what sense you make of them. In the 4 studies which looked at it, all 4 of those came out with that as important as a risk factor. The study's very variable range of physical parameters which were studied. Sometimes this was just a blood count. In other places, it was a wide range of different factors. So you don't want to make too much of that. But by and large, most of these are drawing a blank. So it is this area here, the presence of psychiatric disorder and physical attribution, which seems to be particularly important in terms of prognosis. Now, there may be all sorts of reasons for the overlap, and I'm not going to bang on about this in a way you've sort of heard enough already, and I'm not going to talk about that because time's limited. But I do want to make the point that if this was any other disorder, making these points would not be controversial. Psychiatric disorders matter, not just in CFS. They matter, for example, in heart disease. So that, the relative risk, if you've got depression, your relative risk of having a serious coronary event is increased by about 60% in a number of large epidemiologically valid studies. Psychiatric disorder matters. It's a risk factor for the onset of coronary heart disease. It's also, if you have a heart attack, it's a risk factor for doing badly with the heart attack. No one's arguing that this is the same thing, but psychiatric disorder increases your chance. If you've got a high score on the Beck Depression Inventory, you're more likely to die of your heart attack or die of heart disease in the follow-up period than if you've got a low score. So there is something sort of general about psychiatric disorders which implies maybe a range of biological mechanisms we don't understand, but they matter, and it probably matters that we diagnose and do something about these. There's also the problem about the impact of psychological processes. So I've mentioned already that if you have strong attributions of exclusively physical cause, it's a risk factor for doing badly. And I'm sure Rona's going to talk more about this in the afternoon, but the hurt equals harm cognition, which is something chronic pain psychologists have recognized for a long time, that if you see any evidence of your symptom increasing when you do something, that means that you've got to stop doing it. That hurt equals harm cognition seems to be the most powerful predictor of doing badly, and in cognitive behavior therapy, changing that cognition, so allowing people to experiment a bit further, a bit more, seems to actually be predictive of a good response. The kind of way in which we understand this disorder develops, as psychiatrists, it develops these predisposing factors we've talked about, the precipitating factors, and then this pattern of symptoms where you get into a vicious circle with sleep problems, reduced fitness, increased symptoms upon activity, fear, further reduction of activity, frustration, helplessness, not surprising, anxiety and depression, and this sort of boom-bust overactivity pattern which people get into, worsening of symptoms, and a need then to rest. So a vicious circle can be established. And you can do all sorts of different ways of kind of aligning those risk factors. But basically there's something about having a pattern of perpetuating factors which keeps you unwell. Again, this should not be controversial. If it's another disorder, and this is heart disease again, if you take angina sufferers and you look at their cognitions and you follow them over a long period of time, the people who think every time they're having angina that they're just about to drop dead do less well. The low misconceivers had less anxiety and depression and better functioning at baseline. And the strongest improvement, predictor of improved functioning at 1 year, was a change in angina-related cognition. So improving, changing your cognitions, changing the way in which you view your illness has a predictive value in a completely organic disorder where we're not struggling with any of these nosological problems. And these are the sorts of questions which this study was asking. it's not always necessary for people with angina to stop what they're doing when they get angina pain. Angina is a kind of small heart attack. People develop angina because they have too much stress in their lives and so on. These kind of questions which you may agree or strongly disagree with have a predictive function in terms of follow-up. And here's return to work after a heart attack. So if you view your illness when you've just had a heart attack as something which is going to be very chronic, you're less likely to get back to work than if you view it as something which will get better quicker. If you think it's going to have very serious consequences, and again, in heart disease, your mental health score has some predictive value in terms of your heart attack, in terms of your functioning later on. Okay, so psychiatric assessment should be about taking a good history, and I sometimes slightly glibly think when working, this is not really so much in chronic fatigue syndrome, but when working in a general hospital, that the psychiatrist's role as a general hospital psychiatrist is to go around taking a history. And I apologise to physician colleagues in saying that, but I think that there is, this in a way is our core skill. And we have, it's sort of recognised in the way that we work because we have a long time. We give a long time to taking a history. You need to be thinking about the psychiatric and physical illness exclusions, you need to be identifying suicide risk, and you need to be trying to think about the cognitive, behavioural and affective responses to symptoms which might be driving this vicious circle. It's important to establish the working relationship, and it's absolutely futile to do this if you're not prepared to listen to the story. You have to hear the story, you have to hear about the physical complaints and what happened, and you mustn't be resisting this and kind of scoffing with illness beliefs which you don't necessarily believe in. You need to take account of the experience of not being believed by others. It's incredibly common that these patients come with this awful, frustrating history of trying to make their story heard and they haven't been heard. You need to note the effect and the impact of the illness and allow time and rest periods. I always say, we've got some time to talk about this. If you need to take a break, just let me know. I don't want you coming away feeling much worse than you did to start off with. And then you need to be thinking about the medical differential diagnosis. Well, as a psychiatrist, they've usually had a huge number of investigations, and I usually don't have to go down this path, but you need to be thinking about these sorts of disorders. It may be, I think, probably the group of disorders we haven't talked about very much, probably the sleep disorders, which, do you deal with these as a completely separate entity, or do you see this as a component of chronic fatigue syndrome? And that depends a bit on your understanding of sleep disorders, and I'm not an expert in that field. The psychiatric differential diagnosis. Well, can you explain the disorder by a primary depressive anxiety somatoform disorder? And the things I suppose I'll be going on for the somatoform disorder is this idea that patients with chronic fatigue syndrome have to have an onset which is distinct. So a level of functioning which suddenly changes, whereas most patients with severe somatoform disorders have a level of functioning which has always been pretty awful. So asking the question, when were you last well, is very important, very useful information. And then the exclusions, eating disorders, substance dependence, psychotic disorder, which sometimes get missed. Eating disorders, it's remarkable how thin sometimes people are with barn door anorexia without it being recognised, because people with anorexia often are good at disguising their weightless, their loss of weight. And I ask a few questions, very simple questions about what was going on in your life. Well, when you got ill, but before you got ill, getting a really good picture about what was their life like. Was it this incredibly strained, overactive business of balancing career, school, kids going to school, all the rest of it, and something suddenly snapping? Was there a chronic conflict in the workplace which actually had a very big impact in terms of what happened when you got ill with a viral infection? What were the first symptoms? What did you think was happening to you? What did the doctors say to you? I find this it's very intriguing what doctors say to patients. Of course, you get their report, you get the patient's report, but in our study with people with glandular fever, presenting acutely with glandular fever, what doctors tell patients is rest, full stop. Well, I've had glandular fever, I know what it's like, and you do want to rest, but you don't necessarily want to be told rest from now on till ever. You want to be told to take it easy for a certain amount of time and then gradually build things up when you feel able to. And actually giving interventions which bring about that sort of behavioural change a bit earlier on than they might have happened otherwise does seem to have an influence on chronic fatigue, on fatigue later on. What did your family think? What was going on? I think it's very enlightening, because it may elicit a sort of family conflict. So-and-so didn't agree, thought this was completely ridiculous, or someone else was terribly concerned and driving a process of investigations and doctor shopping, which may have been unhelpful. The present. So when was chronic fatigue syndrome, when was it first diagnosed? You need to think about that. What did you think about? What was your understanding of what this label meant? And what's your understanding now about why you're ill and what keeps you ill? I always ask about a typical day. You can write down exactly what the typical day is, and a bit about what you can and can't do. And try and be quite specific about what you can and can't do, because this has some impact in terms of thinking about treatment later on. You don't want to set the bar ridiculously high. And crucially, the sort of social support and assistance which people are able to get. And then I'd like to ask a bit about what the person's view about the future is. How do you think things are going to be in a year or 5 years? What do you think is the most realistic plan of action for now? Is there anything you'd really like to be able to do which you can't? Do you think there's anything really holds you back from getting better? And really trying to help the patient think about some of the things which might be holding them back, and then possibly relating that to the kind of model of chronic fatigue syndrome I've described, which then is a stepping stone to going on to therapy. So psychiatrists talk about formulations. This is my last slide, Tony. We talk about having a biopsychosocial approach and thinking about predisposing, precipitating, and perpetuating factors. I think this could be used practically in any illness. It doesn't have to be a psychiatric one. But I think that in chronic fatigue syndrome, it's useful because it's trying to make these links. So you imagine someone who may be a woman of 30 who 5 years ago stopped being able to work. She was exercising very extensively, age 25. She was, had burning the candle at both ends. She got into conflict with her boss. There was a viral illness and a set of life events when she was suspended at work or something like that, and she developed a mood disorder around the same time. This is a sort of typical pattern one hears, and then the person gets into a kind of that vicious circle, and you think about these kind of perpetuating factors, the physical effects of deconditioning, particularly for someone who may be used to exercising at a very high rate. And I think it's the differences in perception, which may be very important in terms of that exercise finding. You're looking at the cognitions about hurt equals harm, and what would actually happen if I did more, because last time I did more, I collapsed in a heap. And thinking about some of the iatrogenic processes, which we've heard about already. Thanks very much. I'll leave it there. Thanks very much.